particularly by year 10, you have no difference, not even in local recurrence. So from the NSABP B18, which is one of the very first trials comparing neoadjuvant versus adjuvant, what you have here, the main message is that you can increase the rate of breast-conserving surgery. You have no difference in disease-free and overall survival, and you always consistently from all studies, it comes that achieving a pathological complete response is a very important prognostic factor. And I will not have time to go through that, but even more recent studies took triple-negative tumors from all the different biological subtypes, and even triple-negative tumors, those who achieve a pathological complete response, have a very good prognosis, as if they were not triple-negative. So again, this is one of the main messages. Achieving a pathological complete response is crucial. Another landmark trial was the B27, and this was regarding, and this is one of the messages I wanted to give you regarding the addition of a taxane. In this case was docetaxel that was included in one arm before surgery, in the another arm after surgery. And what you could see is when you include it before surgery, you increase the response rate, and you increase the chances of achieving a pathological complete response. But when you go and see the long-term outcomes, there were no difference between the three arms, and no difference if you look into the arm without a taxane and with a taxane. So no difference in overall survival, no difference in relapse-free survival. And again, this important message: if the patient achieves a pathological complete response, the outcome is much better. So just one small note is in terms of nodal status. I told you that some people say you lose the accuracy of nodal staging. It is true, but still the disease in the nodes after systemic therapy, it's still a very important prognostic factor, even independently of the response in the breast. And so the main messages from this trial would be that if you choose to give two different regimens of chemotherapy, be it with taxanes or with something else, do it before surgery, because then you increase the chances of achieving a pathological complete response. There was another study, and this study gave us a lot of perhaps confusion on what we had thought, that we could use the response to a chemotherapy to decide what to do after that. And this study was the Aberdeen study. It's a small study, but the idea, the principle is there. So if the patients were given an anthracycline-based therapy, and those who responded were randomized to continue the same or change to a taxane. And what you can see is that the patients who changed chemotherapy had a better outcome. And so this goes a little bit against what we thought, that if you have a regimen that it's working, you should continue the same regimen. And in this study and some other studies later on made us be a little bit more confused what to do with those patients who respond. Should we continue the same or change? So just to finalize about the taxanes, my question is, are they really needed? And I would plead at least that if you have limited resources, they are not. And this is by no means a complete list of all the studies done, but what you can see here is that you have consistently an improving response rate, but in the majority of cases, that does not translate in better long-term outcomes, such as better survival. And I have not been at ASCO, but many of you have been at ASCO. And at ASCO, there was a very important study that was the ERTC P53 study that was not just a neoadjuvant study with taxanes, but was a study based on a biological hypothesis that we could identify the patients who needed taxanes based on P53 status. And this was a negative study. And so for at least today, 2010, we cannot determine who will respond to a taxane. And we can certainly not afford to treat everybody with a taxane. And so my plea would be use your resources wisely, and don't think that just because taxanes are spoken about on every single meeting, that those are necessarily the best way to spend the money. And again, remember that the majority of these tumors are endocrine responsive, and that hormonal therapy is a very effective treatment. And so just to remind you that you should not forget, I will finish quickly. He keeps making me signs and making me nervous, but I will finish as quickly as possible. It's difficult to go through the entire treatment in just 15 minutes. But so don't forget about hormonotherapy. And as I told you before, more than half are hormone receptor positive. And for premenopausal, tamoxifen will be, of course, your first choice. And if you can, and it's appropriate, any type of ovarian ablation or suppression would be an added value. For postmenopausal, again, I have no time, particularly because he won't let me, but to explain to you that probably the benefit between an aromatase inhibitor and TAM is so small that, again, it's not worthwhile the money that the difference in cost. And again, focus on tamoxifen, which is probably one of the drugs that save most lives in the entire medicine, not just in oncology. And I will skip and I will not speak about, but you have very strong data from neoadjuvant trials showing that despite the fact that the rates of pathological complete response are very low with hormonotherapy, the response rates are very important. So you do not achieve a pathological complete response, but you do have important benefits at the long term. And I will just wanted to remind you that more and more we have data, solid data from the Oxford overview, from individual trials, showing that tumors who are very high levels of estrogen receptor, so tumors who are very endocrine responsive, derive almost no benefit from chemotherapy. So please keep that in mind. And of course, in this particular case of locally advanced, normally we have to start with chemotherapy to reduce the tumor burden when we don't have to insist. And I will move to my take-home messages, which are my 3 last slides. So the 2 main messages is it's essential to do this decision, the treatment decision and the treatment in a combined way, so in a multidisciplinary team, that the main goal is always to achieve optimal surgery. And for that, you have to decide what is optimal surgery in your local area, if you have radiotherapy available or not. And if you have radiotherapy available, the recommendations for the moment is that it should be given to all these patients, even if a mastectomy is performed, with very individual cases where it could be not given, and we can discuss that in the discussion time. And for in terms of agents, if you have the slow-growing, neglected, locally advanced breast cancer, you should give chemotherapy just enough to render it operable. And usually 4 cycles are enough. And don't forget that CMF is a very good regimen and particularly good for premenopausal women. And so if you have a very good response, you could insist until 6, but no more than that. And if you don't have, or if you have just minor, consider changing for endocrine therapy. And don't forget endocrine therapy either before or after surgery. For the rapidly growing or inflammatory, here normally you need 6 cycles. And if you have a good response and if you have other regimens, you can consider changing to other regimens. Again, not necessarily taxanes, but for example, CMF. And if you have no response, you know that unfortunately the prognosis for that woman is extremely bad. And the only thing that I put down there is because Ben asked me not to speak about trastuzumab because it makes no sense to speak about it since it is so expensive. But of course, scientifically speaking, if you have a HER2-positive disease, you should plead to have access to trastuzumab, but it's another story. And my last slide would be, please don't forget, and I'm sure tomorrow we'll speak more about this, that the pathology and very inexpensive pathology is far more important than certain types of agents, because if you have a lobular cancer, a low-grade cancer, an ER-positive, slowly growing that was neglected, you do not always need to go for chemotherapy. And before I go away and before Ben kills me, I just would like to tell you that you have these flyers all over there that we have put, and this is an effort that we are going to start to try to launch what would be called the St. Gallen of the metastatic and the locally advanced breast cancer. So we are trying to focus not on individual agents, but on guidelines how to manage this advanced and metastatic disease. And you are very welcome to attend. The very first one will be next year. Thank you.